Welcome to this Zoom meeting where we're going to introduce you to 4 experts who will show you that higher blood levels of vitamin D, which is a potent steroid pro-hormone, not just a nutrient, can help to reduce your risk of catching any coronavirus or reduce the severity of the illness. I had the pleasure in 2011 of hosting a conference where 3 of these people spoke. And the first one is Michael Hollick, Bill Grant, and then David Grimes. So this is our agenda for today. Let's continue. Now, who is the target audience for this? We'd like to show this to the experts, and I'm based in the UK, in NICE and SACN and so on. These are the people advising the ministers. And we'd like to show it to the politicians, any doctors and nurses and other medical people, that's great. Health insurance companies would benefit from understanding this. And of course, it's for everyone. Now, they're going to be, in case of confusion, the Americans use nanograms per mil. And in the UK, we use the SI units of nanomoles. So in the UK, we have a definition of deficiency that is set by the Department of Health, probably to save money, which is 25 nanomoles or 10 nanograms. America has 20 nanograms. There's very good evidence that for good bone health, you need 30 nanograms. And there are some experts who issued a call to action who say that they think that the level ought to be, the optimum level is between 40 and 60.
I'm William Grant, Director of Sunlight Nutrition Health Research Center in San Francisco, California. I've been studying vitamin D for about 20 years. Today I'm going to talk about 3 things. One is the mechanisms related to COVID-19 from vitamin D. Second, go over a number of observational studies of 25-hydroxyvitamin D and COVID-19 incidence and severity and death, and then a couple of studies on treatment of COVID-19 with vitamin D. The mechanisms of how vitamin D helps fight COVID-19 are outlined in this schematic. So the circulating form of vitamin D goes to the lung and other organs, including the kidneys, where it's converted to 125 dihydroxyvitamin D, which is a hormonal version of vitamin D, which when it gets to vitamin D receptors, affects gene expression in the chromosomes. So it has a number of actions that are related to COVID-19. It upregulates antimicrobial peptides. It downregulates some of the T helper cell functions. It downregulates the inflammatory cytokines, modulates MMP9, increases the anti-inflammatory cytokines such as IL-10. And that has many important effects on the respiratory system, such as acute respiratory tract infection reduction, inflammatory reduction, asthma reduction, and increase in lung function. Human cathelicidin is a polypeptide with antimicrobial and anti-endotoxin properties. It reduces survival of viruses by puncturing the surface, whether or not they have an envelope. When the innate immune system produces too many pro-inflammatory cytokines, the resulting cytokine storm can damage the epithelial layer of the lungs, vascular system, and other organs, as well as increase the risk of pneumonia. Vitamin D reduces the risk of the cytokine storm, as we've outlined in the paper in Nutrients this year. Systemic inflammation is an important underlying factor, risk factor for COVID-19. Systemic inflammation increases with age, and the elderly have more systemic inflammation due to inflamed aging, and therefore greater risk of COVID-19. The young have very little system inflammation, thus young are much less likely to develop severe COVID-19. And this is shown in a schematic from India, showing that it's the younger people who are more likely to be diagnosed with COVID-19, but it's the elderly who are more likely to die from COVID-19. Furthermore, regarding the inflammatory markers, this shows the relationship horizontally is a logarithm of 25-hydroxyvitamin D from, I think, 10 to 50 nanograms per milliliter. On the vertical, we have the logarithm of C-reactive protein, the normal overview of inflammatory biomarker in the body. So you see that the purplish squares are for people with inflammatory disease. They have much higher inflammatory biomarker than the people with non-inflammatory diseases, shown by the blue crosses. Okay, now I'm going to go into the a quick overview of the observational studies. There have been about a dozen or so observational studies primarily based on either stored 25-hydroxyvitamin D in a prospective study, or 25-hydroxyvitamin D measured at the time of diagnosis. These are generally small studies. The one from Israel actually had 782 people, but the others are anywhere from 27 up to a couple of hundred. And what they're showing in general is that there's an inverse relationship between 25-hydroxyvitamin D and severity of or death from COVID-19. For example, from Israel, there's a odds ratio of 1.95 of having COVID-19 for low versus high 25-hydroxyvitamin D, although they found age to be more important in their analysis. Mexico found that those with less than 8 nanograms per milliliter had a 3.7 times greater risk of death than those with the higher values. So now let's go down to some of these in more detail. The study in Switzerland looked at 27 people who tested positive with a PCR test for COVID-19, and they had a mean 25-hydroxyvitamin D concentration of 10 nanograms per milliliter. Patients who came to the hospital thinking they had COVID-19 but tested negative had a mean value around 25 nanograms, which is just about the same as other patients in the hospital who did not have COVID-19. So another example that there's a significant difference between vitamin D status and COVID-19. Here is a study from Italy. They looked at survival versus 25-hydroxyvitamin D in patients with acute respiratory failure. The mean 25-hydroxyvitamin D was 20 plus minus 12 nanograms per milliliter. So after 10 days of hospitalizations, patients with less than 10 nanograms per milliliter had a 50% mortality probability, while those with 25-hydroxyvitamin D greater than 10 nanograms per milliliter had only a 5% mortality risk. And here's the Kaplan-Meier curve showing out to about 25 days that a few died who had greater than 10 nanograms per milliliter, but almost about half of them died if they had less than 10 nanograms per milliliter. A study from Austria looked at 109 COVID-19 patients and categorized them by mild, moderate, and severe illness. Those with mild had around 25-hydroxyvitamin D, around 65 nanomoles per liter. Moderate had around 55, and severe had around 52. So there wasn't much variation in the 25-hydroxyvitamin D, but there was a trend. And also the parathyroid hormone, which is controlled in part by vitamin D, increased as the severity increased. Now, you're probably all familiar with the UK Biobank studies looking at 25-hydroxyvitamin D data in COVID-19. So UK Biobank recruited over 500,000 participants aged 37 to 73 years between 2006 and 2010. So baseline exposure data, including serum 25-hydroxyvitamin D concentration, were then linked to COVID-19 mortality. But they were using the 25-hydroxyvitamin D for that period 2006 to 2010. What they found was that if they did a univariable and multivariable regression analyses, they got different results. And they had 656 patients with confirmed COVID-19 infection of whom 203 died of COVID-19 infection. So their over a decade-old 25-hydroxyvitamin-D concentration was associated with severe COVID-19 infection mortality invariably, about a 8% reduction for every 10 nanomoles per liter increase in 25-hydroxyvitamin-D. But after they adjusted for the confounding factors, including age and sex and ethnic background, etc., that dropped to 2%. That was not significant. It was also not vitamin D insufficiency was also not independently associated with either COVID-19 infection or limited mortality. But there are two problems with the UK Biobank data for this work. First of all, the 25-hydroxyvitamin-D concentration were obtained too long ago. As I've shown in several publications, if you look at the follow-up period after drawing the blood for 25-hydroxyvitamin-D and look either for all-cause mortality rate or for cancer incidence, as you get to longer times, you lose the association. That's because 25-hydroxyvitamin-D changes with time, changes with season, changes if there's all of a sudden the recommendations on vitamin D supplementation change. People take more vitamin D and that rises, et cetera, et cetera. So you really cannot use 10 to 15-year-old data in biobank with biobank COVID-19 data to get any meaningful outcome. And the other problem was they used too many confounding factors that were directly related to vitamin D in the analysis. So we do have another study from the UK looking at patients admitted to the intensive treatment unit. They were younger, 61 versus 76 years, with greater prevalence of hypertension, higher baseline respiratory rate, higher C-reactive protein. While the mean serum 25-hydroxyvitamin-D levels were comparable, only 19% of the ITU patients had 25-hydroxyvitamin-D levels greater than 50 nanomoles per liter versus 39% of the non-ITU patients. I mentioned earlier that in Israel, they found that the age trumped 25-hydroxyvitamin-D. But this study from the UK with patients with an average age of 80 plus 9 years found that the median 25-hydroxyvitamin-D for those with COVID-19 was 11 nanograms per milliliter, but the median 25-hydroxyvitamin for the controls was 21 nanograms per milliliter. So here, this shows that even at the age of 80, even if they have other chronic diseases, which were not associated with COVID-19, there's still a tremendous difference in the 25-hydroxyvitamin-D concentrations. Here's a study from Chicago. They had people with mean age of 47. Whites were 158. The others were primarily African-American, 331 participants. They looked at 25-hydroxyvitamin-D measured in the past 12 months. And they found that for comparing to the 187 with greater than 40 nanograms per milliliter, those with less than 20 nanograms per milliliter had an 80% increased risk of being diagnosed with COVID-19. Here's a study in Germany showing that if they had greater than 12 nanograms per milliliter, very few people died. If they had less than 12 nanograms per milliliter, 30% died within 2.5 months. Odds hazard ratio of 15. There have been two very small treatment studies. One in the United States had two Hispanic patients with BMI equals 30, baseline 25-hydroxyvitamin-D, about 20 nanograms per milliliter. They were given 50,000 IU per day of vitamin D2 for 5 days. 25-hydroxyvitamin-D increased to 40 to 50 nanograms per milliliter. Oxygen use decreased from 15 liters to 0 for 1. The other had no oxygen requirement. IL-6, the primary interleukin associated with inflammation, decreased from 10 and 14 picograms per milliliter to less than 5 picograms per milliliter. Hospital stay was 10 days for the treated patients versus 13 to 14 days for controls, although the controls had diabetes mellitus and hypertension, which may or may not have affected the hospital stay. Here's a more thorough, this is a study, this is a pilot study in a clinical study in Cordoba, Spain. All hospital patients received as best available therapy, the same standard of care, using combination of hydroxychloroquine and azithromycin. And eligible patients were allocated to take oral calcifidiol, which is 25-hydroxyvitamin-D2. In other words, it's already passed the conversion from vitamin D to 25-hydroxyvitamin-D. And so in the first week, they were getting an equivalent of 130,000 IU of vitamin D2. However, the treatment kicked in faster because it didn't have to go through the liver for the processing. And what they found is of the 50 patients treated, only one required admission to the intensive care unit, while of the 26 untreated patients, 13 required admission to the ICU. They show, and this is turns out to be very significant. Of the 13 patients who were not treated, who were not admitted to the ICU, they were discharged. But of the 13 patients admitted to the ICU, 2 died, and the remaining 11 were discharged. So let me, it's near the end here. I want to say that contrary to what some people think regarding evidence as only coming from clinical randomized controlled trials, observational studies really are evidence. They are based on serum 25-hydroxyvitamin-D levels. They are generally adjust for possible confounding factors, generally finding little change as a result. Results from observational studies are consistent with known mechanisms, and generally for results of vitamin D clinical trials for acute respiratory tract infections and preliminary trials of vitamin D for treatment of COVID-19. So in summary, the severity of COVID-19 is inversely correlated with 25-hydroxyvitamin-D up to and above 30 nanograms per milliliter, perhaps even to 50 nanograms per milliliter. To achieve 30 to 50 nanograms per milliliter, it would take around 2,000 to 4,000 or more IU of vitamin D3 per day. These doses are known to be safe. Risk of death is greatest for 25-hydroxyvitamin-D, less than 12 nanograms per milliliter. Those at greatest risk of death are the elderly with low 25-hydroxyvitamin-D concentrations. Those with confounding factors and obesity should be concerned, but it's really their 25-hydroxyvitamin-D that makes the difference. And many randomized controlled trials regarding vitamin D for prevention of COVID-19 in healthcare workers and treatment of COVID-19 patients are in progress. Thank you.
Thank you all for those great presentations. I'm Rufus Greenbaum. I'm a citizen scientist. I'm interested in preventive health. And as a result of some of my work, my inner age is my real age minus 18. As a scientist, I understand the difference between hypothesis and RCT evidence. I've been corresponding with the UK government about vitamin D since 2009. If you want to see my original letter, follow that link, ISGD RG SACM 2009. I had the great honor and privilege of organizing 4 conferences about vitamin D in 2010 and 2011. And again, you can see those if you look at this link. I currently publish the blog, vitaminduk.com, and I have been commercially involved since 2015. You have to take that into account in what I'm saying. Now, here is the annual blood level of vitamin D in a UK population over a 2 or 3 year period. And you can see, and this is all white-skinned people. These were people born in 1958, and the test was done in 2002, 3, and 4. At the end of the winter, their natural blood level was 35 nanomoles, and it rises to 75 nanomoles in September. It's September the 24th now. This week, we've passed the autumn solstice, and the blood levels will start falling. Now, what do you need to do with vitamin D? It depends on your target. If your target is 25 nanomoles, which is the current UK definition of deficient, well, there's no problem. No preventive action required. If, on the other hand, it's 50 nanomoles, there's a minor deficiency for a few months, And again, there's no major preventive action required. But what if you set your target at 75 nanomoles? Well, now everybody in the UK is deficient all year round. Now what do we do? And if you follow the experts' guidance that says we ought to have 100 to 150 nanomoles, everyone is very deficient all year round. Now, what action is required? And what that means is you have to go from our UK definition of 25 nanomoles up to 100 to 150. You actually have to increase the blood level by 4 to 6 times. This is the A plot from Scotland. Look how low they get. In February, they're down at 10 nanomoles, and they don't get much above 45 nanomoles. They've got a problem in Scotland up at 56 to 57 degrees north. 2 key facts. If you want to understand the importance of vitamin D, you need to accept these 2 key statements as facts. If your blood level is less than 100 nanomoles, then you are liable to suffer from some of 88 different health conditions. And vitamin D is a potent steroid pro-hormone made in your body from sunlight or supplements, and very little can be obtained from food. It is not a nutrient. Second, go away. It's nothing to do with you. Many doctors have been wrongly taught that only a very low level of vitamin D is required, and it's only to avoid problems with bones and muscles. If you persist with this belief, you'll probably reject all the assertions of our speakers and the evidence that higher levels are needed for better health. So read more about it. Here are some links. Follow my blog and Grassroots Health and Vitamin D Wiki. Health outcomes, very good evidence that people with dark skin have lower blood levels of vitamin D than people with light skin. And then when their levels are equalized, then their health outcomes become similar. And this explains why people with darker skin have worse outcomes. Follow that link to look further. If you live further away from the equator than 30 degrees north or south, then you cannot make enough vitamin D from the sun all year round. And in your winter, you will need to find another light source of UVB or take vitamin D supplements. Again, have a look at the shadow rule. There is a delightful talk on TED by Professor Nina Jablonski about the effect of health and skin color and migration. A beautiful talk. Many people who live an outdoor life near the equator, like the Maasai warriors or Hawaii lifeguards, have natural blood levels of 100 to 150 nanomoles. There's an American doctor who walks on a Florida beach every day without a shirt, and he has a vitamin D level of 117. My test results, I take 5,000 IU of vitamin D each day. My last test was 143 nanomoles. But look down the bottom of this slide. The test lab said greater than 50 was adequate. So my doctor's going to look at this and say, you're okay, you're well over the amount. The test labs, DEQUAS in the UK, have to adjust the test result adequate level to be greater than 75 and preferably above 100. How much do I need? How much vitamin D do I need to raise my levels to the lower limit of 100 nanomoles? In winter, I need 4,000 IU a day. In summer, maybe only 2,000 a day. It may be that people are more compliant with a weekly supplement. That's good enough. Obese people should increase the dose, maybe double required. Vitamin D is fat soluble. Larger people have less. Those people who cover their bodies should take the full winter dose all year long. Muslim women, religious people who cover their bodies. If you don't take a loading dose, it may take 90 to 120 days to stabilize. The dose response varies for about 10% of the population. Have a look at Grassroots Health to see a study of people taking large doses. And it's required for life. Many doctors think it's like iron, where you only need a one-off top-up. No, you need it for life. And maybe whole families should be tested or supplemented. Well, what are the next steps? Well, let's monitor and supplement vitamin D levels to greater than 100. The benefit to cost is massive for people at risk. It's an easy, hard challenge. Every step is easy, but making it happen everywhere is hard. Who needs to take action in the UK? Our experts need to understand this properly. NICE, SACN, NervTag, SAGE, and Public Health England. Our politicians need to understand it, and our blood test laboratories need to understand it. Who can take local action? Every doctor and nurse can take action today. Pharmacists can take action today. Public health directors need to understand this and take action. Unfortunately, not all public health directors are medically qualified, but they ought to ask some of the experts for guidance. Health visitors and midwives can make a massive difference, and so can care home staff. And think about what would be the benefit for health insurance companies. The major ones in the UK are Bupa, PPP, and WPA. They would benefit from wide supplementation. Their clients would live longer and pay them premiums for a longer time. So for more information, look at the scientific information on the tolerable upper intake from the European Food Safety Agency. Follow that link. Look at the experts' call to de-action on grassroots health. And for proof that vitamin D works, have a look at Vitamin D Wiki with the section Proof that Vitamin D Works. What are the next steps? Who needs to take action? Everyone. What do you need to do? Boost your vitamin D to 100 to 150 nanomoles. Why? Because you'll live longer in better health. Where do you need to do it? Everywhere. And when do you need to do it? You need to do it now. You want to learn more? Look at my blog, Vitamin D UK. Look at Vitamin D Wiki. Look at Grassroots Health. And vitamindAssociation.org events has videos from my conferences from 2011. I'm very proud of those conferences. They were videoed, they're up on YouTube, and they are a great learning resource. Thank you so much.